And good morning. Welcome to the live stream from Deuk Spine Institute, Surgery Center Vieira. I'm Dr. Ara Deuk-Majan with my team. Our patient is here today with multiple herniated discs in her thoracic and lumbar, both. And she actually has severe stenosis with spinal cord compression and damage. It's going on T12-L1. The spinal cord ends at L1, so these herniations are above where the spinal cord ends. The spinal cord travels down from the brainstem and ends right here. So the herniations here in her back are actually crushing her spinal cord, causing her to go paralyzed. She can't walk without a walker as a result. She also has herniated discs further down at T13-T14 and L5-S1. We're going to be treating 6 herniations today. So let's get started. We're going to be using the Deuk laser disc repair. All right, let's start with 2-3-3-4, okay? Is it the left side? Everyone agree? Left 2-3-3-4? All right. So. Shot. We need to see more of the back, so drop. Can you drop the table a smidgen? I would say that's good. Jordan, I like that. All right, so we're a little higher than we need to be. 5, 4, 3, 2. We need to be a little bit lower, which is good. Shot. 5, 4, 3, 2. Yeah, thank you. Shot. All right. So 5, 4, 3, 2. So 2, 3, 3, 4. That doesn't look too bad there, actually. Let's do some numbing medicine. Actually, some skin numbing. I'm going to give you a little bit of numbing medicine. Don't get upset. You'll feel a little stick and burn. So we're going to numb the skin. There are certain structures in the body that are pain sensitive. Did you do this side?
You can do more.
And there are certain structures that are not pain sensitive. And the skin happens to be one of those structures that's extremely pain sensitive. You may need more of that. You may want to be a little bit lower right here. Blood pressure is good? Yeah. Thank you. Here you go. All right. So the first step in this procedure is to access the disc herniations on each side that we want to using a needle. And to do that, I give some medicine to make the patient more comfortable. I'm numbing up the fascia, the muscles. Those are all pain sensitive structures. Lay still, you're doing great. Shot. All right, so there we have 5, 4, 3. So we're going to start with 3, 4 on the left. Everyone agree? 3, 4 on the left?
Agree, sir. Yes, sir.
Okay. Shot. Shot. There's the facet. I'm touching the facet. I need to wrap around it. Perfect. Shot. Shot. All right, so we're awfully close. 5, 4, 3, 3, 4. Everyone agree? 3, 4?
Agree, sir.
All right. I'm encountering a lot of bone. I think that's what I'm hitting. You can actually see a double shadow of the superior facet of 4. We're off on orbit. So I need you to change the orbit for this level. Shot. I don't know, I think that's worse. Other way. A little bit more maybe, just a tiny bit more. That's as good as it's going to get. Show us the top of the superior facet. See where the needle tip is, folks? That's hitting the superior facet of L4. There you go, right there. And there's actually 2 of them, and they're superimposed on that picture. But before they were offset, meaning that there was some malalignment of the fluoro relative to the spine. You really want to line your fluoro up perfectly to do these procedures. So I'm going to try again from a little bit different angle, a little bit more lateral. I'm going to aim for the same target. Shot. 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 So I'm hitting that facet just barely. Shot. And there we go. That's nice. Shot. So our first herniation is right there at L3-4 left side. Give me an AP. We're going to use the second view, anterior posterior. We're going to look at the needle and the spine from a second view because perfect. The needle and the spine is three-dimensional structure. And because it's three-dimensional, you really have to use more than one dimension or axis to evaluate your trajectory, and localization is fine because we can count the vertebrae on the lateral view. Show us. 5, 4, 3. So the disc I'm aiming for is 3-4. Everyone agree? I like to ask my team because, yes, I am the surgeon. It's my job to know. Ultimately, my responsibility. But, you know, humans make mistakes, and these are not kind of mistakes we want to make. Shot. So getting the right level is important. We call that localization. Where do you feel that?
Where are you feeling that? Your hand still.
Lay still.
Lay still. Where are you feeling that? In your back? Feel it. Where? Where? In your back? She's feeling that in her back.
Don't move, all right?
Try to stay
Don't
still.
move. That's one of your bad discs. We're finding the first one. So she feels that. I'm lightly touching the herniation with the tip, and she started moving. Do y'all see that? That means that is a painful spot. So that's one of the things we're going to be fixing today. That herniation in particular. I hope. If she lets me in. Shot? Yeah, it looks like we're heading in nicely. You're doing great, by the way. Just lay still. You're very helpful to us, okay? So one needle is in position, and everyone agree it's 3-4. The next one is going to be at the level above. So let's take a look. And I want to get my technician, Jordan, to line up that level nicely. Shot. All right, so we're off on WAG. There's a double shadow on the pedicle of 2, and we need to fix that. Shot. That's better, but I think you need to center it. You want to stay for 5-1? All right, I think we can make that work. You got a double shadow on the, show us the double shadow at 3, superior facet. All right, and maybe that's the best we can do. So, yep, show us the double shadow. There, no, go up with your arrow. There, that's one, and then go to the other one on the left of that. There's the other one. So they're offset by about ½ a degree. And that's okay, because if I try to fix that, then the next level may be out of alignment. So I think we're in good position. The two things that we adjust for the most, I'll give her some more numbing. The two things we adjust the most are the trajectory, AP lateral versus, AP versus lateral. That changes. And then the other thing we change once we get into the AP or lateral, and usually just on the lateral view, I'm just giving you some numbing medicine, I'm sorry. The other thing we change is called the WAG, and that's really the CR moving this way, and then the orbit, which is the CR moving this way. Okay, and you want to adjust those. You got to have a really good technician who knows what they're doing. And shot, and you're going to make those adjustments to get a perfect trajectory with the x-ray, because if your x-ray is off on its trajectory, then you're going to be somewhere you're not supposed to be. What I mean by that is you may end up taking a path that you shouldn't be taking. Okay, shot? And you may end up in a final place with the needle where you shouldn't be, shot? That could be dangerous for the patient. So it's important that you, shot, that you make sure your navigational information is accurate. And that means you have to move the fluoro perfectly relative to the spine. So you can see that I take a lot of time. We have literally the best fluoro money can buy. And we have a technician who is extremely experienced in using the fluoro in this capacity. Yep, no, we're good. Just go ahead and give me a lateral. Nicely. So if you count the vertebrae, 5, 4, 3, 2. We're aiming for the 2-3 disc, okay? Transforaminal from the side. We're almost there. I can feel the herniation already. And you could see her moving a little bit. She's feeling it as well. So this is the hardest part of these surgeries, in my opinion, in the back, for the back, is to get the needle from the starting point here to the ending point perfectly. I wasn't born a needle jockey. Dr. Patel, on the other hand, was. And I had to learn the skills of a needle jockey. We call needle jockeying, where you manipulate a needle to get it to where you want it to go. There we go. Perfect. And neurosurgeons don't do this, you know. Of course, we do far more complicated surgeries, but needle jockeying was a skill I had to learn after my training at University of Florida in Gainesville, because it's not something that you're trained to do. We do our surgeries with big incisions, moving all the tissues over and causing a lot of damage to the patient, but honestly, it makes the surgery easier in many ways for the surgeon, but worse for the patient. Once I learned endoscopic surgery, everything changed, and now you become a needle jockey because that's the first thing you have to do. All right, we're right L5-S1. Shot, just lay still, you're doing great. Maybe a little bit higher, starting. Yeah, I think we can do that. Go ahead. We're going to give a little more numbing medicine. We use standard lidocaine and marcaine. Yeah, it's fine. Shot. Shot. All right. Shot. Shot. So I'm happy with the lateral view. There we go. I just hit the facet. Perfect. So I'm going to rotate around it. There we go. It's perfect. Shot. Now she's got a herniation here on the right side that on the MRI I saw it, and she's got back pain in this area as well. L5-S1. Yep. So we're trying to take care of the back pain as well as the leg symptoms. All right. Any questions from the audience so far?
No current questions.
Where do you feel that?
Where are you feeling that?
Lower back?
Low back? Right side low back.
Henry, can you show our audience with our educational video, why do herniated discs actually cause back and leg pain?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, welcome back. And just for those of you who have been with us, you know that we are fixing 6 areas, 6 herniations. We're doing the right L5-S1, the left L2-3, L3-4, that's 3, and then we're doing the right T12-L1 and bilateral T11-T12. Okay? All this will be done minimally invasive endoscopically. You can actually see the outline of her muscle. So I can really get lateral here, and I want to be as lateral as I safely can be. I don't want to be any more lateral than safe. And that's very important. All right, hold on a second. Let's get a shot. All right, so that looks good. I'm lining up nicely, right? So we can see L2, L1, T12. And I'm aiming for the 12-1 on the right side. Everyone agree? 12-1 on the right. Right, 12-1. That's one of our levels. So I'm going to keep going here. Shot. 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 All right, so I'm bumping up against the facet. I may have to start more medial. Shot. Well, I may be able to get this if I just, oh, there we go. Shot. All right. Shot. All right, so we're just about there. Are you comfy? All right, I appreciate your patience with us. Let's go, AP. You can actually see there's even a bone spur there at T12-L1. Yeah, we've already got half of them accessed. Perfect, look at that, absolutely perfect. And you could see the rib. Show us the rib there, Jordan, at T12. Look at the rib at T12, and the 12 rib comes and connects to the pedicle of 12. Show us the pedicle of 12. Yes. So show us the 12-L1 disc space. Yes. Show us the pedicle of L1. Yes. And the disc actually starts from the mid-pedicular. So if you think of the pedicle as a clock face, there you go. Jordan is outlining it. So we're literally at the beginning of the disc. It's absolutely perfect positioning of the needle. All right, we're going to do the disc above as well, but we're going to start with this one. I just have to finish access here. Are you comfy? All right, you're doing great. A lot of bone spurs. I could feel them all. Shot? Yeah. I have to be a little bit inferior. Yeah, you're all right. Now, do you have pain up in this area? Shot? All right, I'm literally just catching on the bottom, like, micron of the bone spur. And there's a technique, there we go, that I use where I twist the needle. And I don't like to use the word drilling, but I actually use the tip to kind of, there's a little bit of calcium deposit or bone spur there, I'll drill. And that's kind of a Deuk spine thing because no one ever taught me that or does that. It's actually a drilling motion. Because if you're hitting a little calcified disc, you do a little drilling and you can open a corridor and get in. And I've been doing that for years. All right, we got 4 out of 6 done, okay? So you're doing fantastic, and I really appreciate you laying still. How's your neck?
Pretty good. I got it on a perfect position pillow. She's a little sticky. Thank you. How are you feeling in your neck? On your left arm or left neck? Left arm?
What's going on?
You said her left arm's a little sore.
A little sore. It's her right arm that's flaccid from her neck surgery. Yeah, I just want to tell our audience, this patient's amazing to me. I mean, what a trooper in life. She's got her family here supporting her, and my heart goes out to her because situation in life is very difficult. She's incapacitated with pain, and not just in her back and thoracic, but also in her neck. Yeah, that's better, Jordan, but you're off on WAG. You see you're off on WAG at 11? If you can, so let's just show everybody what we're talking about, because if you're a neurosurgeon and you're doing spine surgery using x-ray guidance or fluoroscopic guidance, well, I wanted to show them how the pedicle, use your arrow, show them how the pedicle of 12 is nice, right? On the lag view, you see the top, show us the bottom. The 2 pedicles are lined up left and right nicely, but look at the pedicles at the one level above. No, above. Yeah, so there, show us the bottom of the one, there's the bottom of one pedicle, and show us the bottom of the other pedicle above that. There's a black line, a little higher. Yeah, right there. So those pedicles are off. Now, why would they be on line with the fluoro and the next segment is off? And that's because of scoliosis. So there's clearly a lot of scoliosis at this level. We're not going to be fusing the scoliosis. We're not going to be correcting the scoliosis. We're actually, oh, that's really nice, Jordan. My God, that's beautiful. So show us how the bottom of the pedicles are lined up at 11. Right there. Both pedicles, left and right, are lined up. We're shooting down the foramen, right down the foramen. Show us the foramen. Good. Where is the herniation here? It's huge on the MRI. It's actually, yeah, it goes even higher than that. Balloons up. There you go. You can actually kind of see some calcium in it. That's crushing the spinal cord on both sides. So we're going to aim for both sides to decompress the spinal cord. And here we go. Do we numb here? Let's just do, let me just see. Let's do a little bit more numbing right there, right there. Yeah. We're going to give you some more numbing medicine. Now, my anesthesiologist, Dr. Berndes, and I have had many discussions about the use of numbing medicine for this kind of surgery. And it turns out that propofol, which is what we use. All right, so I'm a little bit aiming a little too high. Probably could be a little lower. The propofol burns up the numbing medicine quite quickly. All right, so I love what you've done for me at 11-12, but I don't like the fact that it's near the bottom half of the screen. Is there any way to bring your, no, you got to bring it more north. Wait, let's see. No, sorry, more south. You are correct. I apologize. Let's see if we can get this a little better. All right, not bad. Yeah, you just got the WAG issue again. I would drop the table half an inch. Perfect. Let's take a look. All right, you got to fix that. You had it better earlier. And it's a little orbital issue too. You can see a double ear, rabbit's ears, for the facet below. Just a slight orbital issue. Again, I think you might have made it worse. Shot? Yeah, you made it worse. All right. All right. Try to find it's. You could see the 2 ears again of the superior facet of T12. There we go. Beautiful. Nice job, Jordan. Damn, you're good. All right, well, I don't know. I wonder if I can get both of these through the same incision. It's not exactly next to each other. You know, no. I'm just gonna redirect south. I'm just gonna redirect south and just see if I can get it. Shot? I think we're gonna be okay from here. Yeah, we're gonna be okay. All right. Any questions from our audience so far? Shot?
No current questions, but we do have a comment from Bill on Facebook, and
Yes. Shot?
they commented, "Wow, this patient's awake."
Yep. The patient's awake. I'm awake. Thank God. My anesthesiologist is still awake. Luis? Yeah. So Bill, this is endoscopic spine surgery. This is the most advanced spine surgery in the world for this problem. And the patients are awake and they actually go home an hour after the surgery's over. So not like the brutal surgeries done in the hospital where people are fused unnecessarily. Shot? All right, I feel like I'm getting around the facet. Shot? All right, let's get an AP. You're doing great, almost done. So the reason the patient's awake is because I need their help. If I get too close to a nerve with my needle, I need them to tell me. I need them to tell me I'm too close, you know, I can feel it. That's the best test to know if you're too close to a nerve, is having an awake patient. That's why we do the surgery awake. Once I get past the nerves and I've got my needles in position, then I know we're safe. And I don't need the patient to be awake anymore at that point. I want them asleep because the rest of the surgery will be uncomfortable. But right now, I need her awake. So, once again, a lot of herniation, shot, and bone spur, calcified herniation. Not calcified, but some calcium deposits within the herniation, okay? But not a calcified herniation. Shot? All right, we're making a little bit of progress. There we go. She's a little tight because she's awake and she's compressed her muscles down on my tool. But that said, I'm very pleased. We're making good progress. Shot? All right. So it turns out that this level in particular is one of the worst levels. It has some of the biggest herniation I've seen. And the biggest one that we're going to be fixing today. So for those spine surgeons out there that want to think about endoscopic, you want to try to approach this herniation as laterally, from as lateral as you can safely do. Because by being more lateral, you can get more medial on the herniation. But you can't go too far lateral, otherwise you get into problems. We got 5 out of 6. You're almost done. How do you feel?
You doing okay? She said good.
Shot? Yeah, you're doing amazing. I'm really proud of you. You're a trooper. Now she's from North Carolina. South Carolina. Oh, I apologize. South Carolina, right? Yeah. She said yes?
Yes.
I think it's, is it Charleston, right? Or is it Charleston? They told me we get so many people from the Carolinas that come here. And,
You got a couple in the last 2 weeks, right?
yeah. Mm-hmm. So I may be getting a little confused, but yeah, she's from the Carolinas with her family. All right, so I'm bumping up against the facet. I need an AP. Okay, so we are almost done placing our needles. And just to go through the steps of the surgery with you. Step 1, positioning the patient in the operating room. Yeah, I'm too medial. Step 2, prep and drape. Step 3,
That should be step 1, right? What do you say?
Positioning?
Oh, position, yeah.
Yeah, positioning is 1. Prep and drape, number 2. And number 3 is placing the needles. Number 4 is the actual endoscopic part of the surgery. Shot? Shot? All right. Getting close. Shot? This is the jockeying I was telling you about earlier. Shot? And I'm literally making very small adjustments to my trajectory. Micro adjustments, we call it. Shot? And this is really the hardest part of the whole surgery. Navigation. All right, so I'm very close. Shot? You okay? Shot? You doing all right? Yeah, we're literally a micron from being where I need to be. Sats are good, everything's good. All right, I can see the needle tip. I'm just getting caught up on a little bit of bone spur coming off the facet. But I like the lateral view. I could try to redirect just a little bit. I can feel the spur right at the tip. Shot? All right, so there we are. I need to just redirect a little bit more. Shot? Shot? Oh, too high. Shot? My gosh, just a little movement. Huh? Shot? That's better. Again, we're right on that last bit of facet, but I think we should get it. There it is. All right, again, just literally not even a millimeter, but these are micrometer movements. Micrometer movements. So we're right there. AP? All right, I'm at the back of the disc, and I'm almost inside. Are you comfy?
How are you doing? You okay? I said yes.
Yeah, you can see on that view. Show us where we are there. And look how the needle's gotten to the midline at the right side. The left side, we're right at the entrance to the disc. You see it? No, left side. Yeah, right there. We're about to enter T11-12. So we're able to navigate it, and now we're going in. And by the way, this surgery, the alternative surgery for this is really a major surgery. Yeah, one more. And what I mean by that is you have to do such extensive removal of normal ribs and structures. The diaphragm gets in the way, and it's just very dangerous to do open surgery for this problem. So a lot of surgeons won't do it. You're good. You're good. We're in. We're in like Flynn. All right? Okay. Now, do you have a lot of back pain normally? Yeah? Do you normally have a lot of back pain? More leg pain? All right. So the thing is, she does have also back pain. There's 2 discs up here we're going to be fixing. And we're going to fix 2 there, and then of course 1 down here. Are you comfy? We can start with thoracic if you want. Let's just stay up there. No? Never mind. We're going to start with lumbar.
Boom, boom, boom.
Luis has a system in place. You know, in life, successful teams are exactly that. They're teams. They're never just one person by themselves. And I've got my team looking after me and the patient. So I think we're going to start it. Yeah. All right. All right. So the reason we do this is for several fold. I'll tell you in a minute. Are you comfy? All right. No pain? Not right now. All right. How bad is that on a scale of 1 to 10? 10? All right. I'm sorry.
Is that where you normally get your back pain, honey?
So that's 3, 4. That's 10 out of 10. That's where she normally gets her back pain. We call it concordant. Is it better now? So you can see the pressure came out. A lot of the dye came back out. All right. Any pain right now? No. How bad is that on a scale of 1 to 10? 10. Is that?
Normally get your pain? Yes.
All right. So we just tested L2, 3, L3, 4. She said 10 out of 10. Ow, ow, ow. So great news. Those 2 discs are definitely causing her back pain. Is it better? All right. We're almost done torturing you, okay? But so far the results are exactly what we want and what we expected. How bad is that on a scale of 1 to 10? Is that where you get back pain normally? 10 out of 10 at L5-S1 concordant. Who's marking all these? All right. So we already know. When she came to me, I said, where's your back pain? She said, right here and right here. Okay. And it kind of skipped the disc, the L4-5, which is why we're not treating L4-5. But now we know for sure 2, 3, 3, 4, and 5-1 are causing typical back pain. Every day she gets it, and it's severe. We're going to put you to sleep in a few minutes, all right? We're almost done. We're almost done. Are you comfortable now? All right. How bad is that on a scale of 1 to 10? 8. That's the highest it went was 8? Was the highest? The highest was an 8? 8. So that was, is that where you get back pain? Concordant. So that was the T12-L1. All right. You okay? How bad? How bad is that? The highest it goes is an 8? All right, yeah, you tell us. 8 out of 10. And is that where you get back pain typically? All right, you've done what we need you to do. I appreciate it. So several things I've made observations about. We're going to put her to sleep, number 1. You're going to feel a little burning in your vein in your arm. That's just the medicine going in. Don't be alarmed. Okay, number 1, she's an American. She's patriotic. Red, white, and blue. Red, white, blue. Okay? That's the kind of patients we like here. She is from the South. All right. She's not an alien. She doesn't have green blood. That's the dye we use. And what it does is it stains what's called degenerative disc or degenerated nucleus pulposus specifically. And when we get in there with the endoscope, you'll see that. We're going to put you to sleep. I want you to count from 1 to 100 out loud. Count out loud from 1 to 100. Yeah, keep going. All right, so as she counts, and my anesthesiologist is giving her propofol, which will put her to sleep. Now, some people, after these surgeries, they watch our videos and they say, oh, the patients have 100% pain relief. Isn't that because they're on medicine? The answer is no. Propofol does not do any pain killing at all. It just puts you to sleep. And so propofol as an anesthetic agent is only good for putting you to sleep. It does not make you forget, and it does not take away pain. All right, you ready, Luis? All right, you can see the guide wire in the disc. So I'm taking out, yeah, thanks, Jordan. Show us the guide wire. I'm taking the needle out, but leaving the guide wire. There's the guide wire. So what does the guide wire do? It guides. What's it guiding? It guides the dilator. The dilator is a long cylindrical tube that has a hollow center and it has a tapered end. And the purpose of this, it's beautifully designed. I couldn't improve on it. It's not my design. But the purpose is to spread the muscle fibers and the fascial fibers so there's no damage to anything under your skin. So there's really no damage to the body with this system. This is the only spine surgery in the world that doesn't damage your body. Except for the skin, of course. And you lose a little bit of blood, a few drops, but that's it. Blood is an organ. It's made in your bone marrow. And the kind of blood loss we have with these surgeries is minimal. It's only a few cc's, 1 or 2 cc's. All right, shot, good. So we are now at the L3-4. I'm going to pull the guide wire back a little because sometimes it gets trapped and it starts pushing forward, and I don't want it to push forward into the pelvis, or the abdomen, I should say. Shot. All right, so I can see the tip has been pulled back from the front of the disc. It's in good position. I'm going to advance it, and I use a mallet because in surgery, especially orthopedic type surgery for the musculoskeletal system, a lot of times we have to deliver force to do the surgery, and the best way to deliver force is with a controlled small what's called quantal, small amounts of force, and that's what I'm doing. The alternate, you can see the disc space opening. Show them the disc space opening. See guys, the disc is actually opening up. And you're going to see that space get bigger in just a second as I slowly and deliberately advance the dilator. Take the guide wire out. Look at that, it's open now. All right? Now what allows us to do this is obviously the tapered tip of the dilator, but also I'm advancing it slowly. I'm giving her body a chance to adapt. Yeah. And the adaptation is the muscles are actually relaxing in between advancements, because the more I push apart the vertebral bodies back into their normal distance from each other, the muscles around the spine spasm and tighten down, and that creates pain, but it also keeps me from being able to do what I want to do. So I want to give the muscles a chance to adapt. All right, you can see the tip of the tube is now inside the annular tear and herniation. I think that's good. I could see the oval shape of my tube there. Let's show the oval shape of the tube. Yep, right there. And it's inside the back of the disc. Now remember, I get a lot of questions from my audience. Dr. Deuk, if you're taking the disc out, all right, you're doing a discectomy, what are you going to put in there instead? We're not doing a discectomy, folks. We're not taking the disc out. We're taking the herniation out, and we're cleaning the tear, the annular tear. So it's really a novel type of surgery. Nobody else does. We discovered it here at Deuk Spine, but it's a type of endoscopic spine surgery. It's a type of spine surgery, but the purpose is to eliminate back and neck pain, thoracic pain, and also remove herniations that are pinching nerves. Doing good? Yeah, she's not moving at all. She's great. I wish all of our patients were as good as her. Right? All right, so let's show our audience. Have we shown the video on what does the Deuk laser disc repair actually do? Nice pressure?
Not yet.
All right, let's do that. Do you mind, Henry?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. As you can see through this view endoscopically, that this is the end of the tube you saw in the x-ray. It's sitting inside the annular tear, and that is the annular tear. You're looking at it. Notice it's white, but it also has some pink tissue right here. You see that? That pink tissue is inflammatory tissue. And there's just a wisp of a capillary there just bleeding. And remember, the glass fiber at 12 o'clock, you see it there, that's the laser fiber, is 1 millimeter across. So that gives you an idea of how small everything is here, how precise the surgery really is. That's a 1 millimeter fiber. And look at how well it removes that damaged tissue that's causing the back pain. Now we have two goals here with the surgery. Number one, get rid of her back pain from this disc. Number two, get rid of the pinched nerves going down in her legs. And the way we get rid of the pinched nerve is removing the herniation or bone spurs that are pinching the nerves. It's quite simple. Other surgeons try to do the same thing. However, to do it, they have to destroy the spine, destroy the muscles around the spine. They do a laminectomy, which destroys your spine. But the business area is right here. It's the back of the disc. It's where all the back pain comes from. It doesn't come from the middle of your disc. It doesn't come from the front of your disc. It doesn't come from the side of your disc. It always comes from this exact spot. And that's what we discovered at Deuk Spine Institute. We're the first in the world to discover it, the first in the world to use it to fix people.
We have a question.
Sure.
This comes from Liz Lindsay on Facebook.
Yes, Liz, welcome.
And they ask, may I ask what happened to the patient? What happened to the patient to have these injuries?
Oh, what happened to the patient that gave them these injuries?
Yes, may I? She asked if she may ask that.
Of course. Thank you for asking. So all disc injuries come from the same thing. It's trauma. Trauma to the spine. Basically force applied to your spine that exceeds the limits of the structures that are designed to stop the force from destroying the spine. Okay? So if you think about force, forces are everywhere in our world. We exist in forces. Forces are a part of everyday life. However, excessive force is force that goes beyond the limits of what our body can handle. And, you know, some examples are, for example, if you're scuba diving and you go too deep, you can actually crush your lungs, crush your bones, crush your body. You've all seen the Coke can that goes down to the bottom of the ocean and it crushes, right? So forces around us can actually harm us if they exceed our thresholds. And the spine has thresholds. Okay, it's made up of joints called discs and facet joints. And like all joints, they can be damaged when the forces exceed the threshold. So that's what happened. I don't know her exact story of how she injured so many discs. However, I will tell you there is another factor that's very important, and that is genetics and the way your body is built. And I can tell you right now, from all my years of treating spine problems, degenerative spine problems, that there is definitely a genetic predisposition for people with, I wouldn't say the wrong genes, but let's be honest, the genes that predispose you to spine problems, those genes predispose you to injuries, traumatic injuries. So basically, they don't predispose you to get into car accidents, but they predispose you once you get into an accident where maybe, you know, you and I would have a higher threshold on our spines before they get injured, you know, higher tolerances, they call it, okay? But there are people who have lower tolerances. And so, you know, that's the genetic side. So basically, weaker ligaments, weaker discs, weaker tendons that fail sooner. And that's why there's more than one factor. It's really multifactorial. But trauma is at the heart of all spine injuries. Trauma.
We have another question.
Uh-huh.
This comes from Peggy on Facebook,
Yep.
and they asked, what are the limitations to daily activity after surgery?
Yeah, so great question, Peggy. When you're asking about limitations to your activities and about surgery, I assume that you're talking about the Deuk laser disc repair, this surgery. Every surgery is going to have different limitations. But the limitations for this surgery, you can actually start driving the next day. You can go to work the next day. You're not taking any narcotics. Our patients don't take narcotics. So there's no painkillers. They take Tylenol and a muscle relaxer, and that's it. The restrictions are only with respect to lifting and bending. So our patients are not allowed to lift over 25 pounds for 6 weeks. And that's pretty much true of any spine surgery. And they're not allowed to bend over and pick things up from the ground. I want to get a little bit more. Just want to get as much as I can. So lifting and bending. That's it. No other restrictions. You can go swimming, you can go walking, you can go biking. There's a lot you can do.
Lights on, please.
Golf. People ask me about golf all the time. When can I go back to golf? You can go back to golf within 2 weeks. And you can actually go back to golf even sooner if you really had to. But I tell everybody, give it 2 weeks and let things start to heal. Now, when you go back to golf, you're going to have some restrictions. So the first 2 weeks, 2 weeks after surgery, you're allowed to go back and play a short game, putting. The mid-game, I tell people to wait till 6 weeks, you know, the fairways. And then for driving, I want people waiting 3 months before they really start driving the ball. But it really depends on the activities you typically engage in life. And it's really a case-by-case basis. You know, if you have one herniated disc and it's pretty stable, then you can go back to your activities very quickly. If you have 6 herniations, then you're going to be out for a little longer perhaps, you know, with respect to bending and lifting, so, and other activities. Great question. All right, we're done with one of the 6 discs. Now we have to move to the next one, which will be the L2-3.
We have another question.
Sure.
This comes from Sochik on Facebook. And they ask, how long will it take for the disc to grow back?
Yeah, how long does it take for the disc to grow back and heal? I tell everybody 12 months because I think it could take up to 12 months. I think it could heal less than 12 months in some people, but to safely say it, I would say you want to wait 12 months before you go back to normal full activities of doing anything you want unlimited. I got it. Okay? So, some people might heal at 9 months, but a good safe bet would be 12 months. Shot? Shot? Another thing I hear a lot is shot? Shot? You see the guide wire, right? I see it. Shot? It looks good, right? It's all the way in. It's just hard to tell because she's so collapsed. Another thing people always want to know is, what if I get an MRI afterwards? MRIs will never be normal on your spine once you have a herniated disc. You'll never see a normal MRI once you have an injury to your spine. Whether you have a herniated disc or a bulging disc or a degenerated disc or whatever you want to call it, hold this, because those are structural changes. And structural changes cannot ever go back to normal in a spine. Okay? But what our goal is to change the physiology of your spine. And what I mean by that is the pain in the back and the legs comes from inflammation. And my goal is to get rid of the inflammation in the disc. Now, sometimes there are huge herniations. They need to be removed structurally. And that represents probably 10% at most of the herniations we deal with. So just be aware. Don't expect your spine to look normal. We want your spine to feel normal. There's a difference. Maybe someday in the future, there'll be technology that allows the spine to reverse its structural changes. But in this day and age, at least for the foreseeable future, I don't see ever the discs ever going back to normal after they've been damaged. So what I tell everybody that has a disc problem is our goal is to get rid of your back pain and your leg symptoms, like weakness, numbness, and tingling. Go ahead. Maybe a little bit more. Sorry. And we're not going to make your spine look normal, so don't expect it to look normal. Expect you to feel normal. That's where we are, folks. 2023, the best we can do in medicine, and it is the very best, is to get rid of back pain, eliminate it, get rid of leg pain, get rid of leg numbness, tingling, and weakness, which are the signs of nerve root involvement, or myelopathy, which is spinal cord involvement. But we cannot make spines look normal. Now, compare the Deuk laser disc repair to other, go ahead, to other types of surgery, and after surgery, the most normal your spine will look is after this surgery. Other types of surgery remove bones and ligaments and actually make your spines look worse, far worse. Some put in screws and rods, cages. All right, so we're pretty good in position. We're inside the annular tear, and I'm going to be pulling back, and I'm going to be looking around as much as I can to try to remove as much herniation. But what I tell everybody is we need to get rid of about 50% of your herniation to get rid of your symptoms. And some herniations are going to be harder to remove than others. Okay? In other words, some herniations are easier to remove, others are much harder to remove. Shot? I mean, scope on. Hold on.
Scope on, please. Thank you.
All right, so we're still seeing a lot of the blue dye coming out. That's why it's dark. Just give it a minute and the dye will be gone. There's a piece of herniation right there.
Please, thank you.
That one was actually sitting outside the disc, and then when I put the dilator in, it pushed it in. And that's one of the advantages of this particular technique, is what's called the inside-out technique. And the inside-out technique, we start inside the disc with the endoscope, but we actually have to go across the annulus. So as we do that, we're pushing the herniation back into the disc. And then we take it out from inside. So there's part of the herniation right there. And we're just going to get started here. Let me see the grabber first. Maybe I can you hold the tube as well in position for me? Yes.
Yep.
Lights on, please. Thank you.
All right. Can you see this? Get the, yeah.
Yes,
guys-
we can.
So
Yep.
we just pulled this out at L2-L3, and this is not everything. There's still going to be more. But you can see this is a pretty good piece. It's 2 centimeters long, and you guys see that? That's a piece of herniation right there, okay?
Yes, we do. We see.
All right. So we're going to keep going while you take a break for a moment and try to get more of this stuff out. We're going to, remember, we're going to try to get as much out as we can. How's she? Excellent, excellent. Good job, Omar. Keeping up. Thank you for doing that. That's a pretty good size herniation. Let me see if I can grab that. No. We may need Grabzilla.
See
Me. Yeah, I would just bring it in the room.
it's a bit pretty tired on you. Oh, yeah.
It looks like it might be some herniation at 12 o'clock. I wonder if that's a piece there.
I'm back.
Yeah. Pretty big herniation here. Let's see if I can grab that. All right. Sometimes you gotta jiggle it to shake it out. But most of these herniations, and you gotta understand what's happening here. The herniation of the nuclear material causes inflammation. The inflammation causes scar tissue. And what ends up happening is the patient scar tissue scars the herniation to the spine, the back of the disc. So I'm dealing with the herniation doesn't want to come out basically. So you're fighting it to get it out. It's like a stubborn teenager who locks themselves in their room, and I have to try to, that's a bone spur by the way, I'm trying to create more room to deliver the herniation. So I'm going to see what we can do. Yeah, don't open Grabzilla yet. I may need it. Probably need it. But let me just play around for a little bit, see what I can do. So what I'm doing with the laser is I'm busting up the herniation into smaller pieces, hoping to get it out completely or as much as I can. Here's another piece of it off to the side. But I know most of it, based on the MRI, is over here, medially. So the white stuff you're seeing in the field of view is fat, emulsified. This is herniation in the epidural space. Little bits of it. It's been pushing the fat backwards. You guys see that? Herniation right here?
Yes, we do.
Literally in the epidural space. A little piece of it. So I just busted that up. And I'm going to keep trying to get more medially, just underneath this nerve root. So who has the MRI available? I want to come and look at it. Can we get it ready?
He's ready.
Jordan, are you there?
Yes.
All right, so this is a battle. This herniation does not want to come out. I'm going to try to grab it, a little piece of it. Now the tool I'm using is called a pituitary rongeur. The pituitary rongeur is the spine surgeon's favorite tool when it comes to removing pieces of herniation. Unfortunately, in the case of this patient, the herniation is really stuck. There's a piece. Hold the tube. Yeah. You can actually see the disc opening and closing. You guys see that? If you pay close attention. I need to use the laser a little more. So I'm going back and forth between the laser and the grabber called the pituitary, trying to remove as much of this herniation as I can. Any questions?
No current questions.
Fantastic. Again, the advantage of this particular surgery, there's many advantages of it over open surgery. But one of those advantages is that we're not damaging anything below the surface. We're just spreading it because the dilator is so small. All right. Really need a little assistance with holding the tube in place. As I try to remove all this herniation here. This is part of the herniation is almost like a vein of gold. Look at that thing. You got to follow it, you know, with the laser and the grabber. And again, I'm trying to release as much of the herniation from the surrounding disc as I can. And I'm doing that because it's stuck. The herniation is literally stuck. down by scar tissue. See if I can grab that out at least. We're looking laterally here. And the disc is so collapsed, so it makes it a lot harder to get in. All right, there is more of the herniation I'm going to work on. I'll try to grab a little more, but I don't know if I can.
We had Grapsida already.
Huh?
We had Grapsida already.
Yeah, but Grabzilla won't fit in there. That's the problem.
Yeah.
I can barely get this thing in. You see that? It's literally, there's a piece of herniation. But these are just small pieces, you know? It's not very gratifying. I can't fit Grabzilla in there because it's too narrow. That's the problem. I was trying to remove some of the bone spurs so I could get Grabzilla in. Oh, I think I got it. Felt like I had something there, but let's keep going with the laser. And we'll keep working on this. How's she? Good, thank you. She's doing well. As long as my anesthesiologist is happy, I get to keep working. If he tells me we need to finish this thing for patient safety, then we need to finish it. All right. So far, so good. This is fat, by the way. No. No, we're going to do, I don't know what we're doing next. It's up to Louise.
And then we go to thoracic, and then we finish over there. Because I need to switch scopes. So we need to
All right. There's a nice... Yeah. Thank you. Well, the good news is that, yes, it's the most painful disc for her, and that pain's going to be gone. The thing I'm doing now is I'm trying to get as much of this hidden herniation, because this is migrated. And it's you can see it right there. Let's get some more of it out. Good job, Omar. Way to stay on top. So for those of you who do endoscopic surgery, this strategy here is to keep aiming medially, and you remove a little bit of the roof that blocks you from going medially, like I've done, and try to get more medial. Medial means towards the midline. We're literally sitting right at the edge of the disc. This is all scar tissue from the herniation. Bone spur right there. Just checking laterally once again, because a lot of times you're going to get a lateral part of the herniation. You want to try to remove it as well, otherwise it could cause problems later. And let me see here. This is so scarred down. It's not calcified. There's a little bit of calcium within it, but it's not a calcified herniation. It's still a viable but highly scarred up herniation. I think that's all I can get. Let's see if we can see the nerve root. It should be up here. There it is. You guys see the nerve root right there? It's got the veins on it, the squiggly vein.
Yes, we do.
So I wonder if I can pull a little more of this off the root. Let me try. Get some more pressure off the root. It looks like it's mostly scar tissue right there. But you can see we're right next to the nerve root. And trying to get as much of this stuff off. Let me just show the nerve root one more time. Let me just visualize it. Again, right there. Right there. It's underneath a thin veil of fascia. I'm moving the fascia. But that is the nerve root there. I think I can get a little more. Let me just see here. Let me just make sure. You can see the herniation just coming there. Yeah. How's irrigation? Good? Yeah. I mean, there's not much left that I can get. Let's see what we got there. This is one of the, she's more sensate here, huh? Yeah. So it's kind of cool. I think we're seeing possibly the medial branch of the dorsal ramus right there. You guys see it? The medial branch of the dorsal ramus?
I believe so, yes.
Yeah. That's wrapping around and going to the facet. So we don't want that. That will help ease some of her pain. All right. I don't know how much more I can get. The back of this disc is so collapsed. I'm going to try one more time and see if I can get some more here. I don't see any more herniation except this blue stuff here. And it's very scarred up. You guys see the white color on it? The face of it? I'm going to try to grab some more. It's right there, that bluish thing. All right. I might be able to take a little more of that bone down right there, the part of the superior facet. Just limited. Probably another minute here and I'll be done with this disc. Yeah, there's no way to get more. It's just too scarred up. I think we're done here. I've done what I can. I'm happy. I could be happier, but with the disc collapse as much as it is, I've gotten everything I can. All right. I think she's going to have great relief. The back pain will be gone, at least that's for sure, from that disc. Hopefully the radicular symptoms as well. Any questions?
No current questions.
All right, so 2 down. The next one will be 5-1, L5-S1, and then we're going to move up to the thoracic area. So we're making progress. Switch sides with you. I'm going to switch sides. I'm going to head over to the right side.
We need to move after the pedal to this side, okay? Just be careful.
Thank you, Luis. All right. Any questions? I know her family is watching as well, and everything seems to be going well for her.
No current question.
All right. Let me know when you're ready, Jordan.
Thank you.
No.
Skin?
No, we're all right. I need a C5-1. Shot. Shot. Looks good. Go ahead. Let's do some more num-num here. Shot? Yeah. So this will be in the paraspinal muscles. This should help if she has any muscular pain. Shot? Everything okay? What's wrong?
Oh, nothing wrong.
Shot? Beautiful. Shot? All right, we are heading down to L5-S1 on the right side. It's part of our surgical plan today. And she's snoozing comfortably. A lot of times the surgeon has to steer a little bit the dilator, because there is some play and you want to be sure to make sure it goes where you want it to go and the trajectory you want it to take. Because the guide wire is sticking out a little bit. Huh. Shot? Shot? Take out the guide wire. Shot? Perfect. We're going to do this disc, then I'll do the other two on this side, and I'll finish up with the left T11-12. We've got about 30 more minutes, maybe 40 minutes. This is a longer surgery because we're doing 6 herniations. It's the most we do at one time, sort of taking it to the limit. We used to stop at 4 years ago, and when we saw that 4 could be done safely, let's see. Then we went to 5, a little more. Let's just see if it's there. I think that's it, right? Yeah.
Yeah, I see.
She could. Perfect. And then after we agreed to do 5, and we did it for a few years, and there was great results with 5, then we agreed to move it up to 6. And I'll be honest with you, it really is all the anesthesiologists there. When you have the best anesthesiologist, you can do more of what the patient needs at one time. So as our confidence grew and our safety profile was good, we decided to, rather than make people come back for 2 surgeries, we decided to just treat it all at one time. So you have to have a good team though. All right, let's see the endoscope. I need the endoscopic view right there. Yeah. All right, look at this. So what a difference this disc is, right? Compared to the last 2. Thank you, Jordan. This is a newer herniation, and you can see the billowing. You don't have a completely collapsed disc. You have a softer disc herniation, unlike the other ones, which were completely trashed. So the other 2 discs we just finished are more of a degenerative disc disease, and this is an earlier on in the degenerative disc disease. This is still at the herniation level. The disc is well preserved in height, moisture, architecture. The end plates are well preserved at L5 and S1. So this is a newer herniation for her. And it's not a very big herniation, it's a small one, but you guys saw on the discogram it made 10 out of 10 pain. So clearly still a problem. All right, let's go ahead and show the video of how do people get back pain from a herniated disc.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. You now have had an opportunity to watch our video on, well, how do herniated disc actually cause back pain? This is a prime example. There's a tear. You have the nuclear material from the center that is squeezed into the tear, and that's what's causing the patient's symptoms of back pain. A lot of times that inflammation will spread further back towards the nerve roots and cause leg symptoms like leg pain. Sciatica, most of us know what it is. See the herniation right there? We had during the video, we had another herniation that came out and went up the tube. So we got rid of that one. Here's another piece. You see how the laser is used to cut the herniation down into pieces and remove it little piece by piece. We call it piecemeal removal. Very common in surgery to remove things a little bit at a time. Piecemeal. So our surgeries from Tuesday, if you were there Tuesday watching, our first surgery was a cervical DLDR, and that patient had neck pain, headaches, pain down in his arms. All that went away 100%. He was doing great. Outpatient C5-6, C6-7 DLDR. Now, I saw him in clinic. He does have facet pain, so he's going to need a facet treatment done. And you don't know that until after the surgery, because the disc pain will mask the facet pain. So he'll be coming back for a facet treatment at some point. About 20%, I think, of our disc surgery patients end up needing facet treatments as well. It's not 100, it's not even 80 or 50, it's about 20. Now, who's going to need it? We never know. Never know until later when they present themselves with symptoms of facet joint pain. This is kind of a bigger herniation than I expected, I'll be honest. When I looked at the MRI, it was not too big. So, but what I know about this patient is that she definitely has disc problems that lead to degenerative disc disease, right? So when she herniates in a big way, and the whole disc just totally degenerates over time. So it doesn't surprise me too much to see just how much damage there is at L5-S1, right? Because if you use prior experience, which is what we're using, her prior disc injuries, They all degenerate pretty bad. And she's not that old. She's actually younger than me. I'm not a spring chicken anymore, but she is younger than me, and she's got really bad degenerative disc disease, as you can all see. That said, I really think the surgery is going to fix her problems. So remember, the surgery will never make your disc look normal, so don't expect it to. It's not going to take all the herniation away. Don't expect it to. I get people who have the surgery, then maybe they have some facet pain afterwards. They go and get an MRI, and their discs are not normal. And some people are surprised about it, and I'm not surprised. Just tell them, look, we're not here to make your MRI look normal. That's not what the surgery does. No surgery does that, as a matter of fact. No. Anyway, we got a question from our audience, so we'll take it.
This comes from Vignesh on YouTube,
Hello, Banesh.
and they ask, does anyone do this treatment in India that you know of, sir?
Hey, Banesh. So India actually has, oh, look at that herniation there. India has some very advanced spine surgeons. Okay, so that's the good news for India. My partner here, Dr. Patel, is Indian, but he's here, and he's a top surgeon. But in India, there are definitely endoscopic spine surgeons, but they don't do what we do. They don't do this technique. I think there may be one or two that do. I don't know their names. They're actually on our show here. They come on and they ask questions quite often. I don't know if they're there today, but if you come back in the future on another day, you'll probably encounter them. And you can chat with them over the chat, and maybe you can go meet one of them and have surgery with them if you need it. But the Deuk laser disc repair was created here at Deuk Spine in Florida. And if you want to come to where the very best treatment in the world is with endoscopic, then you come to Deuk Spine Institute. That said, if you're not able to make it and you have to stay in India, there are definitely Indian surgeons doing endoscopic surgery. They don't do what I do, but they do something close. It's not as good. It will never be as good until they change what they do. They call it the UBE. It's called unilateral biportal technique. So if you Google that, UBE, spine surgery, you'll find in India, you'll find some surgeons there. Okay? I will warn you though, they do remove bone at 5-1, like what we're doing. We don't remove any bone or ligaments. We keep your normal spine the way it is. But they're going to take away parts of your spine to do your surgery. So it's still less invasive. Look at the tear right there, guys. Oh my gosh. Where's Carl? I wish Carl were here. All right, take a picture of that. Take a picture of that. That goes into our special pictures, all right? That is an annular tear with inflammation. Look at the inflammation. Isn't that beautiful, how red it is? I want you to show that to Carl.
Copy
Henry.
that.
All right, that's it in real life. Inflamed annular tear. That's what I've been talking about for years. Most of the time you don't see it that good, but that's what causes back pain. Inflamed annular tear. That's why we're removing the herniation here. I want you to show this segment to Carl. And I think they're going to want to put it on the website. So let's make sure we have it saved into our educational videos.
Copy that.
It's a great teaching slide. For those of you wondering what that is, that's the end plate over there behind the laser. Remember, the laser fiber is just one millimeter. I want you to notice something. Look at the tear right there in the herniation. You see that down there? That's right up against the end plate of S1. So this is an annular tear, and this is all scar tissue, and there's more. It's really from side to side, literally the width of the whole annulus. Some annular tears are much bigger than others. This is a giant tear. Giant. It's as big as it gets, all scar tissue here. The scar tissue comes from chronic inflammation. That means inflammation going on for years. This patient's disc problem has been going on for years. And all this scar tissue, all this white stuff here that's golden, orange, and white is scar tissue. What this tells me is there's a lot of inflammation in her system. And it's right now inside this tear and disc, and it's destroying the disc. So hopefully, now that we've fixed it, the inflammation is going to go away completely, and her body will heal the disc, and her blood pressure will be better, her heart rate, her quality of life will be better. All right. Questions?
No current questions.
Just about done. Another 3 minutes here, unless I find something really big, really stuck down. Oh, there's a herniation right there. You see it? Look at that thing coming out. That's a fresh one. Okay? The rest of this stuff around here is old, like this white stuff, old, been there for years. But that's a freshie. Y'all see it?
Yes,
Say
we do.
goodbye. I just zapped it with the laser.
We have a question once more from
Sure.
Vignesh on YouTube. And they said, my mom had undergone OC fusion with FM decompression for cervical myelopathy.
Yeah.
No immediate result after the surgery. We're going to rehabilitate her. My myelopathy grade is 3. Any tip for fast recovery?
Yeah, so first of all, happy to hear she's doing okay, but sad to hear she's not better. It's very common if surgery is not done properly, the patients don't get better. I don't know if the surgery was done properly or not. I would need to look at an MRI and CAT scan, but my advice to you is if the results are not what you expect, with occipital cervical in particular, the goal is decompression of the spinal cord. That actually can be determined on MRI. So if you want to see how good the decompression was done, you check the MRI, okay? And that may be the answer. I'm happy to look at it. We offer a virtual consultation. You can upload it, and I'll look myself. But in general, these treatments we do are mostly for pain, and our patients get out of pain. We don't do a lot of decompression for myelopathy like your mom had. I certainly can do it, and when we do that, we do a posterior cervical laminectomy and fusion. It's unusual to need to fuse occiput unless there's a C2 fracture or occipital cervical fracture or dislocation. So I'm not sure why she would need such an extensive surgery in India. Anyway, a lot of questions in my mind. The most important one is she still being compressed? All right, we're done. And the nerve root will be right up there. You can see the bottom edge of it, the white. See the white? There it is, right there. That's the L5 nerve root on the right. Right there. I'm poking it, okay? There's some fat on top and blood vessels, so it looks good. All right, we're done.
Lights on, please. Thank you.
Beautiful, scope off. We're going to put a little antiseptic just to make sure there's no infection afterwards. We've never had an infection with this surgery. Infections are always possible with any surgery, no matter how minor it is. I've seen horrible infections in people's spines from things like epidural steroid injections, where they do it dirty and the patient ends up with an infection in their spine. Yeah, we've had several. They're from other places, not us. We didn't cause the infection. We treat it, but we don't cause them. Huh? All right, any questions from our audience?
No current questions, but we do have a comment from Vignesh. And they.
Whoa, whoa, whoa. Oh, you're going thoracic. Oh. Wait, no. I want to do lumbar.
You want to T12? It's ready for left. I don't know.
We need to.
12-1, L1.
100%. We need to.
Okay, perfect. Okay, leave it.
Yeah, because we got a big herniation. Yeah, this is not your typical thoracic pain hernia. This is actually a decompression. We need to get the big scope in. Make sure she's nice and comfortable while I go in with this, because we got to try to spread those discs apart. So we're moving up to the T12-L1 and T11-T12. Any questions?
No current questions, but we do have a comment from Vignesh, and they, to replying to what you said, he said, my mom had no pain, only coordination issue and gait.
Yeah.
Pray for my mom. Thank you, sir.
Yeah, we'll pray for your mom. Your mother had spinal cord compression, and we do treat that at Deuk Spine, but that's not something we see commonly. I've treated it thousands and thousands of times over the years with surgery. It can be through the back, like your mother had, or it can be through the front. If it's in the front, we call it an ACDF. If it's in the back, we call it a PCDF. But the most important thing is to get an MRI and make sure the spinal cord has no pressure on it anymore. As long as there's no pressure on the spinal cord, then the surgeon did their job right, and you just have to wait for the spinal cord to heal. It could take a year or longer for that to happen. And the spinal cord only can heal so much. It cannot heal completely, usually, because if it's damaged, it's usually permanently damaged. Shot? Uh-huh. All right, so now we're doing T11-12. Shot? Yeah, perfect. I've got the guide wire in place, and we'll give a little more num-num for Dr. Berndez's benefit.
Doing well, she's good blood pressure.
Thank you. Is there epi in here? Or?
Yes, sir.
So I realize the lidocaine and marcaine typically will get sucked up and bound by the propofol, right? Peripherally? Take them out of distribution? And reduce their therapeutic effect? But what about other drugs?
Reduce therapeutic effect. It's a bloodstream binding. So it binds it in the bloodstream rather than so when you have high concentrations, you don't get toxicity with it. You get an intravascular injection. It's more binding rate when it's in the bloodstream.
So it doesn't bind propofol into the tissues? Just the bloodstream? Huh. I need the dilator.
Oh, you remove already the needle?
Oh yeah, that was a while ago.
But I like to have a lot of local anesthetic because you decrease the amount of anesthetic drastically
Right.
that you have to give the patient, especially over a long duration of time like this surgery.
Let's keep an eye on lungs. Hold on. All right, so at this point we are at the back of the T12-L1. Let's do a quick AP. Hold on. Let me just advance a little more and then I'll tell you to go to AP. Now we are not doing this particular surgery just for pain. This surgery right here is really to remove a large herniation, as much of it as we can, because she's got a thoracic disc herniation, two of them, thoracic lumbar and T12-L1, thoracolumbar, and then also T11-T12. Yeah, beautiful. So you can see the tip of the dilator is right at the disc. And the guide wire actually goes all the way across the disc. So you can also see the rib of L1, and you can see that we're at T12-L1. Sorry, the rib of T12, not L1. Now I did this trajectory on purpose. This is a very lateral start, and the reason I did this is she has a very large herniated disc here and the level above. Shot. And so to be able to get medially as much as I can towards the midline, I'm okay. I'm okay. Shot. Uh-huh. To get towards the midline as much as possible, you want to start laterally and aim medially. Shot. Uh-huh. Just a little bit more, and we should be good. I want to pull up a little bit to aim more anteriorly than posteriorly. Uh-huh. May have to put the guide wire a little bit more. Doesn't want to slide. Let me just see. Take that. All right, go ahead and take the guide wire out. Straight out, if you can. Go ahead. It's almost there. Here, I can see it better. All right. Go ahead. That looks good. Remember, we're not trying to remove the disc, we're trying to remove the herniation and clean the tear in the back. So the positioning there is really nice. And I want to get as medial as I can, and I've done that. I'm just in front of the spinal cord. You know, when we do spine surgery, patients understand there's risks associated with it, and we don't do surgery unless they understand those risks and are willing to accept them. That said, we try to provide the safest surgeries available in the least invasive way possible, but you never know. Nobody ever plans on a complication. Fortunately, we've had a great track record, so let's hope it stays that way. All right. So, we're now at the back of the disc at T12-L1 on the right side. There's a herniation right there. Beautiful. That's not going to be all of it, but that will be some of it. And again, most of you who've never seen this done before, I can tell you from many years of experience, herniations are not a one-time event. They are a multiple event, meaning that the average herniation in my experience has at least 15 to 20 pieces of herniation per disc. We've never published that, and the only way really to do it is to go back and watch all the videos. And I need a research associate to do that. But it'll be the first time in the history of medicine that anyone has ever published that. The nice thing about our surgery is you can actually see every virtually every herniation that comes out. So, and every one of these pieces is 1 or 2 fragments. So, how's she? Good? Beautiful. This is going really well for her so far. Better than I expected. There's another piece. So this already we've seen what, 10 pieces from here?
Yes.
And we're still going strong. Again, this is the T12-L1. This is right where the spinal cord ends. So just at 12 o'clock is where you will find the thecal sac and spinal cord, okay? And we need to remove some of this annulus here that's been damaged and scarred so we can see right in front of the spinal cord. There's another piece of herniation. Notice how smooth it is. See the smooth surface? That means it's been worked on by inflammation. Almost like sanding. It's not coming out on its own. There's 2 pieces. So the inflammation, I've tried to explain to people, is natural part of your body response to injury. I can't even get it out because it's so actually getting hard. And the inflammation, look at how smooth that surface is. Isn't that beautiful? And it's hard. I can't pull it out. It's banging on the scope. So it's clearly scarred up, starting to calcify. Anyway, what I was saying is the inflammatory system attacks what it considers to be foreign. And that's really what back pain is all about, neck pain. It's about the patient's inflammatory system attacking their herniation, causing pain. There's an...
Stop. You're okay, you're good, you're good. Can you change over, please? Lights on, please.
Why does this keep happening?
Like this get bad. The fiber get bad. That's the problem with the fiber.
Take it. With the fat fiber?
Yeah.
Doesn't happen with the thin. Because we're running so much power through it, and we need to reduce the power amount. Huh?
Can you change? That's it. Yeah. Just can you continue?
Yeah. Let Oscar come over here and help out. All right. We're going to have to reset our laser. So far we've taken out about 20 pieces of herniation. How is she? The rest of the disc looks okay. It's not as degenerated as the last one. She's breathing good? Stable? All right, we're just going to wait a minute. Luis, brake scrub. Brake scrub if you need to. Zip looks fine. All right, let's go just do a testimonial while we're waiting. Scope off.
Scope off, please. Yeah, can you grab another one? There should be 2 more.
This is Dr. Deuk, CEO and founder of the Deuk Spine Institute. I'm here with one of my patients, and you've traveled from where to the Deuk Spine?
Idaho.
Idaho, with your lovely husband, and we've had a few conversations. She came here to have her back fixed. How long have you had back pain for?
For over 7 years.
Okay. And what kind of work did you do before you retired, if you don't mind me asking?
It was desk work.
All right. And so you had back pain for 7 years. Did you have an injury to your back, or did it just kind of gradually come on?
It just gradually came on. I actually noticed it first in 2015 when I was gardening and I couldn't be up there for 8 hours. I was into it for about 4 hours and I had to take a break. And as time progressed, my breaks got longer and longer, and the amount of work I did in the garden was less and less.
Understood. And you're retired now. So what's it like having back pain limit your ability to do stuff when you're retired?
For me, it's very frustrating. I can't do that what I want to do. So we kept seeking solutions and nothing was working. They did work for a short while, but that short while decreased over time. It was shorter and shorter. My husband does research very, very well. Through his research, he found you. We read that you can fix my back, and you did fix my back.
That's right.
And I thank you.
You're welcome. So when did you have the Deuk laser disc repair done and the Deuk plasma rhizotomy?
I had those done yesterday in the afternoon. I am sitting straighter than I have. I'm standing straighter. I'm walking normal. It's like, wow, new me.
Look at that smile right there. I hadn't seen that until just now. So
well, it wasn't there yesterday.
yeah, it wasn't there before surgery. And how long have you been not smiling because you've been in pain? I mean, really bad pain. How long has the really bad pain been there?
Well, the really bad pain has probably been over the last 5 years. It's something that was really tough to maintain a positive attitude and try to keep a smile on my face and keep Jeff's hopes up. I tend to be a positive person, but there were times when it does drag you down.
Of course, yeah. It's hard living with chronic pain, and especially with loved ones, they have a hard time, relating. Of course, they want to be supportive, and your husband is a very supportive man, obviously. And he's a pleasure to meet. I know he's an author as well.
Yes.
And so what are you going to do now that you've had the surgery? And you could see actually the Deuk laser disc repair procedure she had done yesterday. You can see right here, we went into the discs that were damaged. You had 2 annular tears. We tested your discs during the surgery, and indeed they were causing your pain. So we verified that with our discogram. And then I went ahead and used the laser to clean up the tears that were causing your pain and get rid of that source of pain for you. And here you are, you're doing fantastic. How much of your back pain from before surgery do you still have?
Oh, virtually nothing.
It's gone.
It's gone.
Cured.
My lower back, I have not been without pain in my lower back until your surgery. It's constant, it's always there. I've never been without it. I'm without it now.
So are you going to go back to gardening?
You bet I am.
All right, very good. And what other things would you like to do now that you have a new back that doesn't hurt you anymore?
The biggest thing I want to do? I want to go fly a kite.
Good for you. Let's go fly a kite then.
That's right.
Well, congratulations on having faith
Oh,
and being
thank
brave
you.
and getting it done.
Oh, not a problem.
Is there anything else you want to say to your fans out there?
I highly recommend Dr. Deuk's Spine Institute, Dr. Deuk personally, to help you fix your back.
Thank you. Appreciate that. All right. Safe travels.
Phew, that wasn't too bad, was it?
It was wonderful. All right. Welcome back. We're removing herniations here once again. Hold this. They're getting stuck because they're too big to come out on their own. Let's see. Maybe we got that one. There's one. They're actually firm, so they're banging against the scope as they're coming out, which means they're very scarred up. Gotten rid of quite a few. I can tell you it's very tight. There's the herniation as well. We need to get rid of all of that. So we're at 3 now? 3's fine. Maybe even take it down to 2.5 if you want. You want to try 2.5? 2.5. Huh? Let's try it. 2.5 looks okay. Let's keep it at 2.5. Oh, look at that herniation. Here comes another one. This thing's big. She doing all right? Let me grab that one down there out first. This is all scarred. You see the orange face? That's all scar. That's from the herniation causing chronic inflammation. Yeah, she had a lot of pieces here. Once again, this is right T12-L1. Huh? It's like 100 pieces here. Huh?
Weren't these the 8 out of 10?
Yeah.
Yeah, I remember that.
Yeah, but we're not doing this for pain. We're doing this for stenosis, which is pretty bad. All right, I need to bring the laser back in. You're at 2.5 now? Oh yeah, look at that. Let me try to grab that out with the grabber. It's just the grabber just cannot grab. It's just too firm. Hey Henry,
Yes, sir.
I need to talk to Troy at some point. Will you remind me when I get out?
Yes, sir. Copy that. We do have a question.
Yeah, anytime.
Yeah.
Just tell me there's a question and I'll be happy to take it when I can.
No problem. This it's a two-part question from Vignesh once more on YouTube, and they said, "My mom had undergone the OC fusion for atlantoaxial assimilation and FMD for congenital compression. What would be your treatment for her, sir? It has been 2 weeks post-op, and please tell any precaution measures that that to be cared to for my mom."
Yeah, I don't know that I have an answer for you about my treatment. I don't make treatment recommendations without seeing patients and without seeing the MRI with my own eyes, so I would refrain from that. That said, she needs therapy. You know, if she has a spinal cord injury in her neck, she needs occupational therapy and she needs physical therapy, both. That would be my recommendation. Good nutrition to make sure surgery heals well, and then occupational and PT. So much herniation here at 12-1. Yeah, Luis, I think there's Definitely a difference. Lower power. I don't know. I'm wondering, what is that? That's just responding to the laser pulse. Sheep body temperature is good.
Yeah, just a little, if we turn off the fan.
You want me to put on ambient? I can have it like push the air to the room.
No, just leave it alone.
Grabber. So many pieces of disc herniation. You holding that tube?
Yes, sir. Okay, sweetheart, you're doing great. Just fix your mask, okay? Come on, put it down.
Lay still. You doing all right? Well, this is where some of the compression is happening. God, herniations are just so bad. It's all scar tissue right there from the herniation. Just behind it is the spinal cord, thecal sac. See that herniation just zapping away? See the pressure on the thecal sac right there? That's the dura mater, for those of you who are wondering. And this is the herniation pushing on it. And I'm trying to remove as much as I can. It's a giant herniation. You can see the laser is doing a good job. But that's the dura right there at the roof. Now, I could put the grabber in there and see how much I can grab out, but look how stuck down it is. It's just super scarred. It's super scarred down. That makes it really difficult to remove safely. All that part that's stuck to the dura. Let me grab that piece out. Looks loose. That's a good one. Hold the tube. All right. Just about done on this one. I'm going to try to grab any of that I can. It's so firm. Ugh. It's so firm. See, that's pretty cool, huh? That's the back of the disc. That's just herniation sitting in the back of the disc, scarred in there. And it's just debris. How's she doing, Berndes? So many pieces coming out, blocking our view. Damn it. Fucking hell.
This is the most sensate decimal so far.
Oh, you said the other one was.
This one,
Grabber.
based on meds and heart rate.
That piece of shit right there. What a beautiful view of the inside of the disc, huh? Once again, we're at the back of the disc where the herniation is. You can see we've gotten rid of almost all of it. There's just a tiny bit left right there. And just the grabber doesn't have the strength. This is about a 1.5 millimeter grabber. And then we're doing the best we can with it. But it's a matter of it's limited in its bite force because of its design. All right, let me try the laser again. Once again, the purpose of our surgery is to shrink down as much of this herniation as possible, get the pressure off the spinal cord and nerve roots if we can. And she doing all right? Yeah, good, good. All right. Little piece of calcified disc. Yeah, I understand.
Complete amnesia with this.
Yeah, I understand. You guys see that? That's the end of the annular tear. It's literally just in front of the thecal sac or spinal cord. This is at, once again, at T12-L1. All right, all the herniation stuff's gone. All right, and I just want to try to get it, if I can. Doesn't look like it's putting pressure, but you never know. I'm going to try again, see if I can wiggle it out. The reason why it's not coming out is, number one, it's really firm, meaning it's scarred up. So it's actually stuck. There. I'm taking it a little piece at a time. Just breaking off little bits. Oh, got a good piece there. Let's try the laser again. I knew this would be a long surgery because of so many levels and how bad the disease was. I had my Wheaties today. Knowing I'd be doing battle with this thing.
I had a Bialy.
Yeah? With a schmear?
With a little schmear. Yeah, I found a place that sells good Bialys.
Well, you can see the decompression is pretty much done. I'm just whittling away at that little last bit of herniation, and if I can't get it safely, I can't get it. We can't keep the patient under anesthesia all day. It becomes a risk-reward equation that doesn't make sense if you just keep going at something that all right, I don't see any pressure. I've kind of reduced it towards the disc, and I've broken off enough pieces of it. I think we're going to be all right. You know? Looks pretty good there. Let's see here. Maybe a little more here. This has kind of wedged itself up in front of the fecal sac. A little bit of herniation in there in the epidural space. Just behind the vertebral body. There's a little bit sticking out there. Now there's this concept of gilding the lily, which you really, oh yeah, nice. See that? Where you want to avoid the so-called gilding of the lily, where you have diminishing returns. Yeah, I think there's a tiny little bit there, but I'm not that concerned about it. I don't see it being compressive. I think that looks really good. I'm pretty much done. I'm just cleaning up lateral, and we're going to close this up. Looks good. That's as much as I can get. Let me just take one more peek here. Really, when you're removing a herniated disc, what you're doing is you're debulking. Here's the epidural space. Oh yeah, baby. Yeah. Remember, you're not going to get every little bit of disc material out, so don't even try. That's just putting the patient at risk for a complication. Oh yeah, there's a piece right there. I would like to try to get more of that. I love how the laser energy is delivered in such a way that it causes the pieces of herniation to move. Basically, it can actually help you quite a bit. All right, looks good. That's not putting pressure on anything.
Lights on.
So,
Lights on, please.
great. Was there any more questions?
No current questions.
Scope off.
Yeah, no current questions.
2 more to go. This is hard, you know? Oh. Yeah, I think that's a great idea. Thank you.
Let's turn on the machine. Let's switch the fluid fiber, yeah.
What's wrong?
No, I want to this time turn off the machine and switch the fiber. I don't know if that affects the machine when we decide to get back to the video.
What you got there, Henry? Any questions or comments?
No current questions. We do have a comment from Vignesh on YouTube who says, very thankful for the response even during surgery. Thank you, sir.
Yeah, my pleasure. Sorry I can't give you more information, but you know, we do offer a virtual consultation at Deuk Spine. We do type in that address. It's deukspine.com. deukspine.com/VC for virtual consultation. deukspine.com/VC. All right. She's doing good, right? 2 more to go.
Good, and you switch it already?
We're just waiting for the fluoro. Whenever you take your time. Wait, we're not switching scopes.
Yeah, you're thoracic now.
It doesn't matter, I'm doing lumbar.
Are you sure?
Positive. We're not switching
It's up to you,
fiber.
it's up to you.
Of course it is,
Yeah,
no.
you wanna...
We're going with the lumbar scope.
Okay.
Yeah. You just saw T12-L1,
Yeah,
T11-T12 is not going to be much different.
Okay.
So,
So we stay the same then.
yeah.
Don't worry. Yeah.
Remember, this is not a pain surgery. This is a decompression. I need to get as much of that stuff
We
out
stay
as
the
I
same, yes.
can.
So, no, we need, yes, please. Yeah, let's switch the fire back.
All right, do you have a nice testimonial you can run for our audience? We've got about 30 more minutes, maybe 25, 30 more minutes.
Yes, I do. Give me 1 sec.
Oscar, please. That wire. Thank you.
And I'm Dr. Deuk here at the Deuk Spine Institute. I'm smiling because I'm sitting with my first surgical patient of 2023. I don't know if you realize that, but you were the first one of this year,
Okay.
of the new year. Now, you had the Deuk laser disc repair done on your lower back because you had 3 bad discs, and we did that yesterday.
Yesterday, yes.
And here you are, 1 day later. How do you feel?
And I feel good. I feel good, and the pain that I've been suffering for months is gone. I mean, I was a little bit sore, but that's from the surgery itself.
Yeah.
But otherwise, I feel good. Feel good.
Now, you've had back pain too, on and off for 30 years. We were talking about that. Tell us about those episodes of back pain. What do they do to you?
The first one that I recall was pulling out a sofa bed thing. And I got so far with it, you know, we had company and I was opening up the bed and all of a sudden I just could not move. I couldn't move. My husband had to practically carry me. So I was out of work for a week or so and then at the chiropractor and then gradually it got better and I thought, well, that's fine. And I moved on and then, you know, had a couple other times like that. One time I was drying my hair, getting ready for work with the blow dryer going like this with my hair and all of a sudden it's like I couldn't move. I couldn't move my arm down. I couldn't, I mean, it was that quick.
Yeah.
And just, I was out again for another week, laying in the bed and doing all that stuff. And then I thought I was fine, but I always, not always, but for many years now, probably at least those 30, I had lower back pain, where in the morning I couldn't bend over to brush my teeth. You know, that would really hurt.
Yes.
So I had that.
Do you have that pain now?
No, I don't think so.
It's gone.
The pain this morning, I was the first time in a long time I've gotten up first thing in the morning and was able to walk and not have that awful pain, because first thing in the mornings was the toughest.
I'm so happy for you. So how is this surgery going to help you in your life?
Well, hopefully I can, once I can at least walk again. I was not able to barely walk with a walker. I was very active in my church and my community.
So you want to get active again?
And being in such pain now since July, and this is the new year, I'm anxious to get back to, you know, my life.
Yes, of course. Well, you had 3 herniated discs in your lower back, and you can see in the footage where we went into each of those 3 discs, and I used a laser to clean the tear, where you had a tear in the back of each of those discs called an annular tear, and the jelly from the center was stuck in the tear, holding it open, allowing more herniations to come out. So I got rid of the jelly that was in there using the laser, cleaned out the tear, and now your body will be able to heal that for the first time in 30 years. So I don't expect you to ever have that pain ever again.
Thank you.
You're welcome.
I am so thankful.
Well, you had faith
I
and
am.
you found us.
Yes, I
and
did.
You did what's right for your body, and I'm excited for you. So
I believe I did. I just kind of was led to you, and it just all went bing, bang, boom, and I didn't ask a whole lot of other people what they thought. I just did what I thought was I needed to do
Good.
for me.
Is there anything you want to say to your fans out there?
I would recommend that if you do something to your back, that you take care of it early on. You take care of it right away. The longer you wait, the harder it is and the longer it takes.
Takes a toll on your life.
Oh, definitely. It has taken a toll on mine since this summer, for sure, where I have not been able to sometimes not function at all, barely be able to sit in a chair and be comfortable without squirming because I couldn't find that exact place where I didn't have pain. You know?
I don't see you squirming anymore.
No, I'm not squirming. I know. That's great. Sit here without pain.
Congratulations.
Thanks to you.
All right, have a blessed day.
Thank you. You do as well.
Welcome back. We are working on the right side at T11-12, and so far so good. I felt good about the last one, T12-L1. This disc is extremely compressed. You could see the sclerosis, which is the thickening of the bone, the end plates at T11-12. You guys see the darker coloration? Jordan, you want to show them? Yeah, see the darkening there? That's thick bone.
Yes, we do.
The reason the bone is thick is because there's arthritis. Severe arthritis and instability. The body reacts to abnormal movement and instability with thickening of bones. Anything? Think you're going to get it? No? Here's a little moisture on this if you want. That will help.
Eat it a little bit and then.
Yeah, in a minute if this doesn't work. Ready?
You got it? Yeah.
I am useful. You hear that? Reaffirmation. I am useful. Are we on testimonial?
We are not. No.
Oh.
Yeah.
All right. Well, there you go. I am useful. A proclamation. You know, whenever the disc is severely collapsed, it's always hard to get the tube in properly. It's compressed severely, and I had to use my He-Man strength by the powers of Grayskull. Here you go. You know, cartoons. My opinion on good cartoons. Good cartoons like Bugs Bunny, Woody Woodpecker, Mickey, Minnie, the Coyote, the Roadrunner, Porky the Pig. You know what I'm talking about, right? Looney Tunes, isn't that what they're called? Yeah. Really good. Good for kids. Don't stop showing them those cartoons. I watched a lot of those as a kid. Very formative. I'm sorry if I offend anybody about SpongeBob, but not a big fan. It's funny, my father was a very intellectual man. And he always told me, because we were the television generation. I guess that's what we're going to be known as, the TV generation, right? If you think about it. Because this next generation, they're all on their phones. So they're the phone generation. I was the TV generation. And he always said to me, you can watch TV, but you can't watch anything, any stupid programs. But he let me watch cartoons, right? I came from a strict family. I was not allowed to watch TV during the week, during school. Only on the weekends, and only after homework was done. Your weekend homework was done. So I usually found myself watching TV at home one night a week, and that was our highlight, you know, playing outside and watching TV. That was when we had good programs like Magnum PI, Dukes of Hazzard, A-Team. Look at the needle there from the other side. You guys see it? The metal needle?
Yes, we do. We have a question.
My favorite cartoon?
Well, that, but
All right, go ahead.
yes, but a two-part question from Vignesh once more on YouTube. He asked.
Big Nash.
Yes.
He's getting them in today.
I'm
I'm impressed.
Is there any medicine support for the spine to heal, sir, or any medicine is under research?
Well, Big Nash, I don't know if you're asking me about the spine or the spinal cord.
I think it's the spine.
Well, the spinal cord is what he was saying his mom was having problems with. So if it's the spinal cord, that's different than the spine. And there is no medicine we're aware of that makes your spinal cord heal faster, but I'm starting to see that there may be some new treatments coming out with medicines that you can be given IV if you have a spinal cord injury that are reducing the risk of permanent damage. A lot's changed in the last 20 years with respect to spinal cord injuries, and I think it's just a matter of time before we do have medicines available. Okay? I don't think it's far off. And of course, when they're available, they should be available around the world for people to use. But I'm starting to see more research on prevention of spinal cord injuries using medications. And what I mean by that is not the initial spinal cord injury, but what we call the secondary injury, right? That's going to be your ischemic swelling and ischemia to the tissue causing damage. Ischemia means not enough blood flow because of the swelling. See, the problem with swelling and trauma is that this is all pressing on the spinal cord, by the way. This is all part of the herniation. The problem is that when you have swelling, your tissues get less blood flow. And the spinal cord, it needs a lot of blood flow. Same thing with the brain. When the brain is traumatized and the pressure inside the brain goes up from swelling, then you actually get less circulation of blood to the brain at the microcirculation level. So you have less perfusion, and then you get this secondary injury. Same thing with stroke, right? We all know that stroke causes damage to the brain if it affects the brain, and then the brain swells as a result of the stroke, and the swelling causes additional injury. All right, this herniation here is pretty old. You can see how calcified it is, and I'm just removing it bit by bit, little piece by piece. Laser's doing good. So Luis, timeline on finding me one? How long?
Within a couple of weeks.
Is there nothing available?
I mean, I can find you one available, but 30,000, 40,000 is good for you?
What?
30, 40,000?
Yeah, but does it have a warranty? Is it refurbed? Is it reliable? Yeah, I need you to look, okay? Oscar helping you these days? I know we've been busy, but I need something here as a backup, right?
We have another comment. And another question from Vignesh on YouTube.
I think Bignesh has run out of questions.
He did mention, I forgot to tell, my mom got FMD for basilar invagination. What are your thoughts on basilar invagination, sir?
Well, you're talking about a very rare condition. Basilar invagination usually occurs with patients with rheumatoid arthritis, and it's where the skull basically sinks down on top of the spine and the tip of C2 goes into the foramen magnum and presses on your brainstem. So the typical treatment is odontoidectomy through the mouth, transoral odontoidectomy, followed by, posterior instrumented fusion. So I think that's reasonable as long as that was her diagnosis, which I assume it was. But, I don't see a lot of basilar invagination. It's extremely rare. Just about done here, 2 minutes on this side. I'm trying to get between the spinal cord and the back of the vertebral body. A little bit of herniation there. For the most part, things are going quite well. A lot of arthritis, see the orange stuff is all calcium from chronic inflammation. But honestly, this is all so scarred up. Let's see what we can grab, if anything. Yeah, basilar invagination, very rare condition. Typically there's a history of inflammatory arthropathy, like, there's nothing I can do there. There's the herniation. That's part of it. I think I can do a little bit more. Let me see. Well, so your mom has a very unusual diagnosis, and I think that as long as they decompressed her spinal cord, that they've done the best they can, it sounds like. The rest is up to her recovery, getting good therapy. See, this could never be done with the cervical scope, right? So I've removed as much as I can remove safely. Maybe a little bit more right here.
So you would say T11-T12-L1, can we always use a lumbar, or is case by case?
Oh, I would do, no, it all depends on what we're doing. So if we're just treating pain, it's small herniation, then the cervical scope is fine. But I would say any of the floating ribs, which is your T10, 11, 11, 12, 12-1, that's all lumbar. Yeah, because you got floating ribs, right?
Correct.
So you're able to do more with the lumbar. And the reason is the vertebral bodies are bigger, right? They're bigger. Because they're bigger, you can get the big scope in. Almost done here.
We have another question from Vignesh.
Yes.
They asked, does any implants have any warranty, or do we have any privilege, sir?
Implants don't have a warranty. No. It's not a car, toaster, refrigerator. I'm going to try to grab that. There's no warranty. They break. And if they're not, put in properly, they break very often. So, spine surgery is not easy to do because it requires a lot of planning and having the right um, fixation, the right reconstruction and realignment, and the right decompression. Those are the three tenets, hallmarks, components of really good spine surgery. And it's very hard to achieve all of those. But the hardware, it's going to fail if your surgeon does not design it properly and put it in properly or select it properly. So there's failure because the materials are not good, and there's failure because it's not put in properly, and there's failure because the patient doesn't do what they're supposed to do afterwards, and there's failure because the patient's body may not be able to accommodate what's being asked of the implants. So, for example, if the patient has osteoporosis, then I'm almost done. I think most of that's just scar, and I'm not going to remove scar because that's not what our goal is here. But we're in front of the spinal cord at this point, and trying to make sure I'm not leaving any herniation behind that I can see. So there's always stuff I can't see. Can't do anything about that. But the stuff I can see, that's another story. Let's see if I can grab one more thing. So there's many factors that determine whether or not the construct or surgery will be successful. I can't get past that. It's too flat, too compressed. All right. All right.
Good. All right, lights on, please. Thank you.
Yeah. I've seen everything in spine. The failures, is the scope off? Yep. I've seen many failures of surgeries for various reasons. Inadequate decompression, inadequate realignment, inadequate instrumentation or stabilization, basically, which is your instrumentation and fusion. So as long as the surgeon does a good job with those three things, decompression, realignment, stabilization, then the outcome of the surgery will be optimal. It may not be perfect. You may not get a full recovery of neurological function, but you will have the best that human beings can do today. And to have those kind of results, you need to have, I want to do one more irrigation.
One more? Yeah.
You need to have really good surgeon. And there's a lot of bad surgeons. I mean, a lot. I don't mean bad as in evil, I just mean not well trained. They don't understand principles of spine surgery very well. And they certainly can't execute a good surgery. So you got to be careful who you trust to take care of you and your loved ones. I wouldn't just trust any spine surgeon. All right, I'm going to go back for our last disc. Want to switch? What's wrong? No. No, leave it.
Yeah.
I'll take care of it. Is it loose?
No,
Any questions from our audience?
No current questions, but we do have a comment from Vignesh saying, I know the patient's relative undergoing surgery will scold me. Sorry, guys.
I'm sorry? Whoa.
I was trying to read this correctly. I know the patient's relative undergoing surgery will scold me. Sorry, guys. It's from the Vignesh.
Why would they scold him for asking so many questions?
I don't know.
You're allowed to ask questions.
Yeah.
That's why we have the broadcast, so you can. Everything's going well from an anesthesia standpoint. She's doing really good. Oh no. That's what you're upset about. Yeah. Did I weld it? right, shot. Shot. And shot. Yeah, that blood is coming from the other side. So it's coming through the disc where we just operated and coming out. So it's not a big deal. Shot. Shot. Just put pressure. All right. Where did I blast it? It looks like maybe right there, right? Yeah. I blasted it with the laser. Everyone says, oh, can the laser do bone spurs? Absolutely. It can melt steel. Like right there, I just showed you. It melted the steel. Huh? It was a hot weld. Yeah, that was a real weld. That wasn't a cold weld. We do get cold welds too. Last one. Whew, this has been tough, I gotta say. It's been several hours, huh?
We're approaching the 3-hour mark.
Yeah. Well, we're just about done. So, God willing, we'll be able to help this woman and her family. Doing the best we can.
We have a question from Sochik on Facebook.
Sochik, sure, sir.
They asked, can this procedure be a possibility to relieve arthritis spine pain or pain after infusion surgery?
Hi, Sochik. Can this surgery be used to relieve pain even after spine surgery? The answer is yes. That's what this surgery usually does most, is it's used to treat pain in the spine that comes from disc problems. And some people don't have disc problem as the cause of their pain. They have something else called facet pain or sacroiliac joint pain or piriformis pain. But if you have disc pain, this is, I think, the perfect surgery that you can have in the world for disc pain, because we're actually going right to the disc to fix it. And the only damage we're doing to the body during surgery is the skin incision. Of course, you can have a complication where there's additional damage, but all the other spine surgeries done, they all cause damage to your spine and to your muscles. And surgeons just take that for granted because they think that's the only way it can be done. But now we know that we can actually fix people's discs without opening them up and doing open spine surgery.
Extractor, please.
All right, this is our last disc. It's his number T11-12. On the left, what is it?
On the left, yes. Can I have a right take, wet right take, please?
You need me to get my biceps involved? You got it?
I think so.
Nice job. All right. So we've got about 10 more minutes. If you have questions, this would be the time to ask. We're going to be wrapping up a 6th level. It's taken us a considerable amount of time because of how difficult the surgery is. This is not normal to take this long, but she has severe degenerative disc disease and extensive scar tissue, as you could see during the surgery, which really takes more time to treat the problem. Plus, we're doing thoracic, which is really difficult as well because of the anatomy. And this side will have a little bit of blood because, well, we just did the other side, and the other side still has some blood in it.
Where's my pictures? I want yours.
All right. Here we go.
Blue towel, please. Thank you.
I would say 10 minutes, doctor.
He's doing very well.
All right, laser fiber. Where's my pedal?
Somebody needs to
Oh, here it is, here it is.
Thank you.
It's just a little buried.
We have a question.
Sure.
This comes from Carla on YouTube,
Hi, Carla.
and they asked, how does the annular tear in a cervical herniation repair itself, and can it herniate again while healing? If so, how do you prevent it? How do you avoid the nerves during the surgery?
Carla, great question. So, thank you for asking. When we repair a disc, we use the laser to clean the back of the disc where the tear is. And see the blue stuff right there? That's stuck inside the tear. That shouldn't be there. And the blue stuff is what's keeping the tear from healing. That blue stuff is called the herniated nucleus pulposus. Herniated nucleus pulposus. That keeps the disc from healing. So by going in with the laser and the grabbers, removing the herniated nucleus pulposus, that allows the tear to heal. But you also have to clean the tear. So you can't just grab out the herniated nucleus pulposus, because that doesn't work. You have to clean the edges of the annulus, which is the part that needs to heal. And if you don't clean the edges of the annulus with the laser, you're not going to be able to heal the disc properly. So what I'm doing right now with this laser is the key to getting the disc to heal, whether it's cervical, thoracic, or lumbar. It's called the Deuk laser disc repair. We're the first to do it in the world, and we're the first to publish it, and we're still doing it today, and nobody else does it. There are probably a few surgeons now that watch my videos and have learned the technique and trying it, but you have to have a laser in order to do it properly. And most people don't buy a laser because they're expensive, very expensive.
We have another question.
And these are not cheap lasers like the ones you go to the chiropractic or physical therapy and they use a laser on your skin. This is a medical laser, FDA approved, top of the line. If you want to buy a new one, it's over $100,000, close to $150,000 US dollars. So this is a special laser, and look what it does. It's the key to the surgery. If you don't do the laser, you're not going to get the results. That you're not going to get the disc to heal itself. Have to do the laser part. Yes. What's the question?
Next question comes from Canes25 on YouTube, and they asked, can a bone spur be too large for the laser?
Can a bone spur be too large for the laser? Yes, absolutely. A bone spur can be too large for the laser. That said, there's lots of bone spurs in people's spines as we get older. And most of those bone spurs are nowhere near where the nerves are. And most of those bone spurs are not symptomatic, meaning they don't cause any symptoms. So we leave them alone. We're not doing a bone spirectomy. Nobody needs to do a bone spirectomy. There are bone spurs that need to be removed from time to time, but the vast majority of people's problems in the spine is not bone spur related. It's disc related, related to a disc. Yeah. A disc problem, not a bone spur problem. 5 minutes. See the herniation right there?
Yes, we do.
Again, another big herniation here at this level. And as I've said many times before, we're not going to be able to remove all the bone spurs or even all the herniation. We're going to remove part of it. And the part we remove, we want that part to count. So it has to be the right part. The part that takes away the back pain, takes away the leg symptoms. That's our goal. And if you could tell from the surgery, we're not doing a laminectomy. Laminectomies, I feel, in this situation, where the problem is the disc, we want to do a disc surgery, not a lamina surgery. So there's a lot of doctors doing laminectomies that don't work, and patients are suffering through those surgeries and really not getting any better. Or if they get better, it's temporary.
We have another question.
Yep.
This comes from David Scott on Facebook.
Hi, David. Welcome.
And they asked, I am a PT, and I'm wondering how is this different than a discectomy with debridement?
Then a facet debridement?
Than a microdiscectomy with debridement. How is this different from that?
Oh,
Yeah.
sure. Yeah, thanks for commenting. If you actually go to our YouTube channel, you can actually watch the microdiscectomy. Maybe you can, I don't know if you have that available.
I actually do.
All right, why don't we run the microdiscectomy video so people can see the difference.
A large incision is made. Muscles are torn from the spine. Substantial bleeding occurs due to muscle trauma. Normal, healthy bone is removed to access the herniation. Stabilizing ligaments are removed in order to access the herniation. An incomplete portion of the herniation is removed. Dense scar tissue forms. Weakened bones can fracture, leading to instability and pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. We're just about done with this surgery. 6 disc parts fixed. And we just had a question from our audience. They were saying, you know, how does this differ from a microdiscectomy? We just showed you the microdiscectomy. The problem with microdiscectomy is that microdiscectomy really is destructive. Can you hold the tube? Microdiscectomy from the video is a big incision. That incision you saw is around 30 millimeters. This incision is 7. So this is 4 times smaller incision, number 1. Number 2, microdiscectomy requires you take the muscles and strip them off the spine. You saw that, right? It caused bleeding. And we're not stripping the muscles off the spine here because we're going to the side of the spine through a natural opening called the neural foramen. And because we're going through a natural opening, there's no stripping muscles off the spine. We're spreading the muscles, going through them, but not damaging them. So that's another big difference. Third of all, you saw in the microdiscectomy that they remove lamina. They do a laminectomy. We're taking bone out, normal bone. Bone, there's nothing wrong with it because they can't get down to the disc without doing a laminectomy. On the other hand, we don't have to do that. We actually we go around the side of the spine. Okay? So we don't remove bone, or lamina. The next difference is we don't remove the ligament under the lamina. You guys saw that ligamentum flavum get taken away? We're not taking the ligaments out either. Those are supporting ligaments. They're necessary to keep your spine stable and healthy. Microdiscectomy takes the ligament out, called ligamentum flavum. Okay? The next difference is the microdiscectomy, they have to reach around your thecal sac, try to get to that nerve, and then move the nerve over, try to get to the herniation. We're not moving the nerve over. The nerve is just outside. You can see the nerve right there. You guys see it? That white thing? That's the nerve. And we're just below it. So this looks pretty good here. can't really do a little bit more. That's bone spur right there, by the way, in case you're wondering. One more minute. Great. Done.
Okay.
Yeah, we're done.
Lights on, please. Thank you.
So, the microdiscectomy is destructive. It destroys your normal spine, lamina, ligaments, and also the facet joint. You saw how the surgeon had to remove part of the facet joint with a microdiscectomy. We don't take your facet joint out with this. We go to the side of the facet joint, leaving the facet joint alone. So basically, the long story short, microdiscectomy, very destructive. Laminectomy, very destructive. Deuk laser disc repair, non-destructive. Number two, microdiscectomy doesn't repair the annular tear. If you don't repair the annular tear with the laser, you don't get rid of back pain. So all the people with microdiscectomy and laminectomy still have back pain. That's why surgeons fuse, to get rid of the back pain. Well, we don't need a fuse because we're actually treating the source of the back pain with the Deuk laser disc repair. All of that is done with, in the lumbar spine, a 7 millimeter incision.
The suction, you can turn off all the suction and everything like this.
7 millimeters. And normally, no bleeding. Today we lost probably 5 cc's of blood, which is nothing. With normal spine surgery, you're going to lose hundreds of cc's. Today we lost about 5. Lay still, you're doing great. So take a look here. Just for a second, you guys see the incision?
Yes, we do.
That's 7 millimeters. Bring in the ruler.
Can I have the ruler, Oscar, please? Thank you.
Here's the ruler, okay? There's your endoscopic incision. Maybe 8 millimeters today. If this patient had regular back surgery, the incision would be from here to here because you're treating so many discs. So what a difference. Minimally invasive, no general anesthesia. She doesn't have a tube down. For a microdiscectomy, you need a tube down. You have to do it under general. And of course, afterwards, the patients end up re-herniating quite often, at least 10%. 10 to 50% of the patients re-herniate. Depends on the technique used. So microdiscectomy is a horrible surgery. We don't even do it anymore at Deuk Spine. I won't do it because it's so destructive. And the patients still have back pain. They end up needing a second and third surgery. Little pressure here. There's no bleeding. I'm going to call the EBL 5 mil for the whole surgery. I thought it went great. Thanks, everybody. That was a tough one. It's one of the hardest ones we've done. I'll take your questions, folks. Type them up. I'm going to come talk to you directly and finish the surgery off with a direct Q&A. Why don't you show them one of our patients?
And I'm Dr. Deuk Majan here at the Deuk Spine Institute. I'm smiling because I'm sitting with my first surgical patient of 2023. I don't know if you realize that, but you were the first one of this year,
Okay.
of the new year. Now, you had the Deuk laser disc repair done on your lower back because you had 3 bad discs, and we did that yesterday.
Yesterday, yes.
And here you are, one day later. How do you feel?
And I feel good. I feel good, and the pain that I've been suffering for months is gone. I mean, I'm a little bit sore, but that's from the surgery itself.
Yeah.
But otherwise, I feel good. Feel good.
Now, you've had back pain too, on and off for 30 years. We were talking about that. Tell us about those episodes of back pain. What do they do to you?
The first one that I recall was pulling out a sofa bed thing. And I got so far with it, you know, we had company and I was opening up the bed and all of a sudden I just could not move. I couldn't move. My husband had to practically carry me. So I was out of work for a week or so and then at the chiropractor and then gradually it got better and I thought, well, that's fine. And I moved on and then, you know, had a couple other times like that. One time I was drying my hair, getting ready for work with the blow dryer going like this with my hair and all of a sudden it's like I couldn't move. I couldn't move my arm down. I couldn't, I mean, it was that quick.
Yeah.
And just, I was out again for another week, laying in the bed and doing all that stuff. And then I thought I was fine, but I always, not always, but for many years now, probably at least those 30, I had lower back pain, where in the morning I couldn't bend over to brush my teeth. You know, that would really hurt.
Yes.
So I had that.
Do you have that pain now?
No, I don't think so.
It's gone.
The pain this morning, I was the first time in a long time I've gotten up first thing in the morning and was able to walk and not have that awful pain, because first thing in the mornings was the toughest.
I'm so happy for you. So how is this surgery going to help you in your life?
Well, hopefully once I can at least walk again. I was not able to barely walk with a walker. I was very active in my church and my community.
So you want to get active again?
And being in such pain now since July, and this is the new year, I'm anxious to get back to, you know, my life.
Yes, of course. Well, you had 3 herniated discs in your lower back, and you can see in the footage where we went into each of those 3 discs, and I used a laser to clean the tear, where you had a tear in the back of each of those discs called an annular tear, and the jelly from the center was stuck in the tear, holding it open, allowing more herniations to come out. So I got rid of the jelly that was in there using the laser, cleaned out the tear, and now your body will be able to heal that for the first time in 30 years. So I don't expect you to ever have that pain ever again.
Thank you.
You're welcome.
I am so thankful.
Well, you had faith and you found us.
Yes, I did.
You did what's right for your body, and I'm excited for you. So
I believe I did. I just kind of was led to you, and it just all went bing, bang, boom, and I didn't ask a whole lot of other people what they thought. I just did what I thought I needed to do.
Good.
For me.
Is there anything you want to say to your fans out there?
I would recommend that if you do something to your back, that you take care of it early on. You take care of it right away. The longer you wait, the harder it is and the longer it takes.
It takes a toll on your life.
Oh, definitely. It has taken a toll on mine since this summer, for sure, where I have not been able to, sometimes not function at all, barely be able to sit in a chair and be comfortable without squirming because I couldn't find that exact place where I didn't have pain. You know?
I don't see you squirming anymore.
No, I'm not squirming. I know. That's great. Sit here without pain.
Congratulations.
Thanks to you.
All right, have a blessed day.
Thank you. You do as well.
And good morning, I'm Dr. Deuk Majin. I'm here with one of my lovely patients from Canada who's visited us because her back has been hurting for 7 years. She's had a herniated disc that she's been kind of monitoring at L5-S1. And finally, it really started bothering her a lot over the last 7 months to a year, causing pain down into her right leg. So she decided to do something about it, and she went to see her doctor in Canada, who then said, yeah, I'll have you see the specialist in 3.5 years. Well, that wasn't going to work for you, right?
No.
Yeah, because you don't want to live in pain for 3.5 more years. And even then, you don't know what you're going to be offered. But she found the Deuk Spine Institute and learned about the Deuk laser disc repair endoscopic surgery. And you had it done yesterday.
Yes, yeah.
How are you doing?
I'm feeling great today. I have no pain in my back. I have some tight muscles from me having to walk very oddly for quite a while due to the sciatic pain. I must say, this is the happiest I've been in a very long time to be able to stand up straight and go for a walk. Because I'm an active person as is. I ride horses for a living, so having to be locked up in my room for the past while has not been good. So this has felt amazing, amazing.
So you're happy with the results?
Very. I feel very hopeful.
I'm sorry to interrupt the video, but we need to wrap this surgery up. Everything has gone well. We're done. I just walked out of the operating room here at Deuk Spine. We were able to fix 6 different spots where there were herniations, and these herniations were causing this poor woman a lot of grief. Number one, they were causing horrible back pain, thoracic as well as lumbar. And then they were also pinching the nerves off to the side where we went in with the endoscope. They were pinching the nerves right there. I showed you a few of those nerves during the surgery. And we were able to clean out the herniations that were pinching the nerves. Again, people always want to know, are you getting all the herniation? The answer is no. No surgeon gets all the herniation. It's impossible. We do the best we can with the surgical approach we're doing. And the goal really, in my opinion, from my many years of doing this, you want to get rid of, to decompress, you want to get rid of about 50% of the herniation at least. And then you try to go for 100 obviously every time, but you cannot get 100. So you're going to have to, once you get in there, you start looking around, you start moving your tube. A lot of it depends on how collapsed the disc is. Remember, the tube is actually sitting at the back corner of the disc, right, like that. And so if there's enough disc space, you can kind of move your tube around, looking around for herniations in sort of a pattern like this, right? Lateral, medial, inferior medial, superior medial, inferolateral, and of course you're going in and out of the disc with the surgery. So you're able to get rid of quite a bit of herniation, but you're never going to get 100. I think probably the most I get is 90%. Maybe I got lucky once, got 95, but after doing this 1,600 patients plus, I feel the average for me is probably somewhere around 80-85% of the disc. So it's not surprising after surgery, you look at an MRI, you're not going to have normal discs, period. We're not doing surgery to make normal looking discs on an MRI. If we were, I wouldn't do surgery, because there's no point. You're not going to. The point of surgery is to get rid of symptoms and signs. Signs are things that we find on the exam. For example, I have a lot of patients, I'll check them out. Hey, are you having any weakness in your legs? No, I'm fine. And then I check their strength on their foot and they're really weak because the nerve's been pinched badly. And so a lot of people don't even realize they're weak, because what happens is the weakness happens slowly from the nerve getting pinched gradually from all those little herniations, getting bigger, bigger, bigger over the years. And when the nerve is getting pinched slowly, a lot of people don't even realize it's happening. And so when I see them and I check them out, I check their strength, their sensory, their reflexes, straight leg raise, all these tests we do, and sure enough, the nerve's getting pinched and damaged. So the reason they don't realize that is, of course, it's slow, and we call it insidious, and they compensate. So, for example, if you're weak cocking your foot up while you're walking, okay, if I make you weak today, suddenly, then you're going to catch your foot every time you take a step. It's going to drag on the carpet or the floor, and you're going to catch it, and then you're going to feel like tripping. So you're going to be, wow, I got a problem. But when you gradually increase that weakness over time, people start doing what's called a steppage gait, for example, where they're bringing their knee higher in order to get the foot to land right. So higher, and they're picking it up higher on one side. And then they start having, hip pain because they're actually stressing the other hip more on the other side. So your biomechanics or body mechanics of walking and standing change when you have pinched nerves, especially if there's weakness happening. That said, she had profound weakness. She's got like every disc in her spine affected. And then I found out she also has problems with her cervical spine, where a surgeon did surgery, and she has like a totally flaccid right arm. She can't even lift it up. It was done 10 years ago. And the surgeon did her surgery in the back of the neck, which I never do because it doesn't work. And it didn't work. And she still has the weakness in her arm. So what are the lessons? Please avoid bad surgery. How do you do that? Find a very, very special, good surgeon who can do a great job. Look for their results. Look at their patients. Their patients will tell you the results. Yeah. Any questions?
Yes, we have, this is a two-part question from Carla Noble.
Henry brought his glasses, so I'm going to
Yes.
wear his glasses today,
No worries.
just so I look really cool.
Yeah, they look good. They do look good. This question from Carla, two of them. How do you avoid the nerve if you have to pass by it? And if the cervical herniation is in the back, does that mean that you are putting a hole into the part of the disc that is not herniated? And is it possible that the entrance hole will cause a new herniation?
Well, Carla, a mouthful, isn't it? So the cervical herniation is in the back of the disc. You are correct. And to get to it, we literally have to pass from the front of the disc through the annulus jelly all the way to the back, okay? And we don't put a hole, we displace the fibers. So if you jump in a swimming pool, dive in, do you put a hole in the water? No. I mean, I don't know what you call that a hole, but I wouldn't call that a hole. A hole is when you make a hole in something and it stays there. But if you spread the fibers apart in the disc, like in the front of the disc, which is what we do, so we come in with a tapered tip, we push through, it literally separates the fibers. You go in and you do your laser surgery and then you come out and the fibers go back together. There's no hole being made. You're just spreading. We've talked about this many times in past broadcasts, but you're not making a hole. And no, the jelly won't come out through the front. And even if it did, it doesn't matter because it doesn't cause any symptoms in the front. The other question was, the first question was what?
The first one is, how do you avoid the nerve?
How do you avoid the nerve? Okay, so let me show you how to avoid the nerve. That's why the patients are asleep for the beginning, okay? But let's take a look at this little model we got here and I'll show you how we avoid the nerve. All right, so this is the back of the spine and this is the trajectory we take. First of all, of course, I avoid the nerve because I'm a neurosurgeon. I'm trained to avoid damaging the nerves. But when I put the needle in, I come in this way, I touch the facet, and then I go to the side in front of the facet. I go just underneath the nerve. You see that?
Yeah.
That's where the herniation is. So I literally push the herniation in and we're under the nerve. The nerve is there. We're under the nerve and we're pushing the nerve over and holding it over. It's called retraction. Very standard in spine surgery or neurosurgery. Retracting the nerves. That's how we do it. And then the tube comes down and it protects the nerves from being damaged during the surgery.
All right. And last but not least, we have a question from Sochik, and they asked, can this help with SI joints?
Can this surgery help with SI joints from Sochik? Sochik, great question. We have a new technology for SI joints. This laser endoscopic will not fix the SI joint, but we have a new technology. It's called Deuk plasma rhizotomy. We've actually done patients with SI joint pain. We come in and we basically use plasma to cut and kill the pain nerves that run from these holes out and go to the joint. So we kill the pain nerve right at the hole. Yep, it's a rhizotomy procedure and it's not done RFA, it's done with Deuk plasma rhizotomy. So come to the Deuk spine and we can do that procedure, and usually it's one and done. You get it done and you don't come back. All right, well, if you're interested in the sunglasses, let us know. Type in the chat box. Henry will be happy to fill you in on the details. I'm borrowing them from him.
Yeah.
Are these Israeli?
No.
Dude, these are cool.
Thank you.
What does that say?
Pugs?
Pugs.
Yeah,
Pugs. Pug sunglasses.
Yeah.
I think,
Beautiful.
yeah, the Zohan wears sunglasses like this, right?
I think so, yeah. The Zohan, yeah.
The Zohan.
Oh,
we love the
yes,
Zohan here
yes.
at Deuk Spine.
Don't mess
All right.
with it.
Have a great day. Hopefully this patient does well. We'll let you know soon, and hopefully she'll share her story with you. God bless. We got one more surgery to go. This lady next, we're going to be doing Deuk laser disc repair, L2-3, L3-4 opposite sides, and then we're going to remove her spinal cord stimulator generator. So if you want, we can show that. You can watch us remove a spinal cord stimulator generator. The stimulator wasn't doing anything for her, and she wants us taking it out, so we're going to.